to today's episode of Myeloma Crowd Radio, a show that connects patients with myeloma researchers. I'm your host, Jenny Ahlstrom, and we'd like to thank our episode sponsor, Celgene, for their support of Myeloma Crowd Radio. Now, we've learned over the last few years that what patients do at the beginning of their treatment can really chart the course for their long-term outcomes. And I learned about a study recently for newly diagnosed patients that I was so impressed with. On today's show, we'll be learning about this study. Not only does it use some of the best therapies in the myeloma arsenal today, it also looks at how patients respond to the therapy to know how long the maintenance or follow-up therapy should be. This is called risk-adapted therapy, and it better personalizes myeloma care. So with us today, we have the principal investigator on this clinical trial, Dr. Luciano Costa of the University of Alabama. Welcome, Dr. Costa.
Good morning. Thanks for having me here. It's a pleasure to talk to you and privileged to share some more information about the study with your audience.
Oh, yeah, it's wonderful. We're looking forward to it. Let me introduce you before we get started into questions. Dr. Luciano Costa is Medical Director for the Blood and Marrow Transplantation Program and Associate Professor of Medicine in the Division of Hematology, Oncology, and Transplantation at the University of Alabama at Birmingham. Dr. Costa received his medical degree and PhD in Brazil, his home country. He is Associate Editor of Advances in Cell and Gene Therapy and has published over 100 articles, books, and posters on stem cell transplant and multiple myeloma. Dr. Costa's research interests include strategies for stem cell transplant and population outcomes in blood cancers. So again, we're so happy to have you. Why don't we start first with the general treatment landscape for newly diagnosed patients? As things have evolved in treating myeloma, we have better drugs, we have more drugs. What are some common themes that patients may want to consider?
Absolutely. So you're absolutely right that the myeloma treatment has evolved substantially in the last 20 years, and that has clearly affected the newly diagnosed setting. Evidently, that's the one line of therapy that virtually every patient with myeloma goes through. However, just based on how new drugs are developed, it's usually that's where new drugs are less used. As a new drug gets developed, it first gets its value proven in the relapse setting and only subsequently in the newly diagnosed setting. So that remains is always a challenge because you can see new agents having very promising results in patients with relapsed myeloma, and it takes sometimes 5 to 10 years to see that new strategy or that new drug to help patients who are newly diagnosed. So, but as you said, the current landscape of newly diagnosed patients is really dominated by a combination of immunomodulatory agents such as lenalidomide and proteasome inhibitors, particularly bortezomib, and patients who are not particularly old and does not have any significant comorbidity do tend to integrate autologous transplant as part of the initial therapy. So I think if you do a survey throughout the country, the most commonly used strategy for newly diagnosed younger and fit patients tends to be the combination of bortezomib, lenalidomide, and dexamethasone, followed by autologous transplant, followed by maintenance therapy. Patients who are older or more frail, who are not considered candidates for high-dose chemotherapy and autologous transplant, are often treated with triple therapy nowadays, the majority of patients. But instead of proceeding with autologous transplant, they do a finite number of cycles and then evolve with maintenance therapy. So this is certainly these strategies yield far better results than we have 10 or 15 years ago. But there are still some important shortfalls. I would say, first and foremost, even though those strategies can have response rates that are in the neighborhood of 90%, many of those responses are partial responses. And even among the patients who do obtain a complete response, the majority will experience a relapse later on. So I would say those treatments are better than they used to be, but they're still not sufficiently effective. On the opposite side, you might have some patients who have an extremely sensitive disease and might be obtain a very deep remission very early on, and some of those patients might be able to discontinue therapy without jeopardizing their outcome. The problem is we have for the longest time lacked adequate tools to measure depth of remission beyond what can be obtained with a regular marrow exam or protein electrophoresis. So what results from that is that we tend to give a fixed treatment plan for all patients, and unless the patient becomes refractory and the disease progresses or the patient becomes intolerant, they tend to all undergo the same number of cycles of therapy, the same transplant, and the same indefinite maintenance therapy. And I think if you talk to patients, as I do, what you hear from them is some patients are very dissatisfied with the fact that their responses are not complete. They are very dissatisfied that with the fact that even though their disease at times may become undetectable, a relapse is eventually going to happen. And other patients are very unhappy with the idea that in order to have a somewhat normal life and get the most benefit in terms of disease control and survival, I have to be on therapy indefinitely. So I think those would be the main challenges for upfront therapy, is to be able to adapt the intensity and the duration of therapy to the speed and depth of response, and perhaps be able to identify patients who might have had a deep enough response that they might be able to discontinue therapy altogether without jeopardizing their future.
Right, and I think this is a really important point because, as we know, all myeloma is not the same. So I have a friend who has been on multiple, has had multiple relapses, but has been on multiple therapies and is still out 20 years. And I have friends who have done like tandem autologous transplants and even an allo and now is out 20 years. So, not everybody responds in the same way. Not everybody has the same type of myeloma. And wouldn't it be great? What
Absolutely,
you're saying is if you could figure out who should get how much therapy, that's really, really important.
I agree. And the tremendous work has been done on recognizing some biological distinctions between patients who do very well from persons who do very poorly. What we haven't done yet so effectively is to use that knowledge to translate into therapies that are adapted to a patient risk profile and to adapt to a patient speed and depth of response.
Mm-hmm. It's very, very important. So this is great. And in my opinion, in my understanding, this is one of the first studies to look at this type of risk-adapted idea.
I believe so. So the study that we have started, we call the MASTER, and that stands for monoclonal antibody sequential therapy for deep remission myeloma, has really been developed for the last 2 years. We aggregate a group of somewhat ambitious myeloma investigators who also happen to be my good friends and colleagues. And what we saw in the near future was the emergence of new drugs that have a potential to be transformative in multiple myeloma, particularly monoclonal antibodies. So we propose to use daratumumab that, as we know, has made a tremendous impact in the relapse setting, along with carfilzomib that we now know has proven, at least in the relapse setting, as being as a more potent proteasome inhibitor than bortezomib, along with lenalidomide and dexamethasone. And we also sensed the opportunity to utilize minimal residual disease assessment, not only as a surrogate for outcome, no longer as an endpoint, but also as a decision-making tool. So this trial, after multiple interactions and some pretty intense discussion and negotiation, the final product is a trial where all patients receive 4 cycles of this combination of carfilzomib, lenalidomide, dexamethasone, and daratumumab. And patients are subsequently treated with an autologous transplant, unless the patient is not eligible for some particular comorbidity or age. But we intend to proceed with transplant on all patients who are candidates, recognizing that transplant has a proven role in induce deeper and durable remissions, and is the best therapy, or I should say the therapy with the best tracking record of clearing minimal residual disease. And beyond the transplant, patients can receive up to 2 blocks of 4 cycles each of the same combination of KRD plus daratumumab. But the innovation, the greater innovation, in our opinion, is not only bringing this combo to the upfront setting, which we have other reasons to believe is going to be a very effective combo, but also be able to tailor therapy to the depth and speed of MRD clearance. Even though we are collecting traditional response assessment, that's not the endpoint of the study. The primary endpoint of the study is obtaining clearance of minimal residual disease. And the study design calls for complete interruption of therapy once you have 2 consecutive measurements with MRD below 10 to minus 5 level of detection. Those patients will then discontinue therapy, be watched without maintenance therapy, but they will be monitored very closely by the traditional serum electrophoresis immunofixation, free light chain, urine electrophoresis immunofixation, but also by measurement of MRD in the bone marrow sample at fixed intervals to make sure that those patients who are now being watched with self-maintenance therapy do not see reemergence of the myeloma clone before even become symptomatic. So I think you are absolutely right. This is one of the first trials to use MRD as an endpoint of therapy, and I suspect it might be the first trial, at least the first trial that I'm aware of, in the newly diagnosed setting to use MRD-based response adaptive therapy in multiple myeloma.
Yeah, that's fantastic. So as you describe the study, you give the 4 cycles of daratumumab and KRD before the transplant, and then everyone goes to transplant. And then when you're deciding who to, and you said you have 2 consecutive measurements of MRD negativity, which means you can't find any myeloma cells at a really deep level, and we'll talk about this later. But for patients who don't know what MRD negative means, it just means that you're looking at a very detailed level of disease detection. And if you find nothing in 2 consecutive measurements, then you can stop that therapy. And for people who still have remaining disease, you keep going.
That's correct.
My question is, how far apart are these 2 different measurements? I mean, right after transplant, when are you doing that?
Yeah, very good question. So the very first measurement is at the end of induction, even before the patient goes to transplant. The second measurement is after transplant, And the subsequent measurements will be after each block of 4 more cycles of KRd Dara. So with this design, the earliest a patient would stop therapy would be after induction and transplant. And the latest the patient would stop therapy would be after induction, transplant, and 8 more cycles of KRd Dara. And for patients, and I'm sure it will be some, that go through the whole treatment plan and are still MRD positive, then we recommend that they continue on maintenance therapy with lenalidomide, because that is considered a standard of care. So this has the potential to be a longer therapy for some patients who are slow at clearing MRD or who do not clear MRD, or they could receive 4 cycles, transplant, and 8 more cycles. But it also could be a shorter therapy for patients who have a more responsive disease, where they would receive 4 cycles of KRd, transplant, and no consolidation, no maintenance therapy.
So you would do two blocks potentially, and then after the 2 blocks, you would go to lenalidomide maintenance. Is that right? 2 blocks of 4 cycles? Is that what you said? Did I get that right?
After transplant?
Yeah.
Yes. So
okay.
You're absolutely right. So let's say a patient who turns out does not clear MRD, then would have 4 cycles of induction, transplant, up to 8 cycles of consolidation, and then go on lenalidomide maintenance.
Okay, yeah, that makes a lot of sense. So let's talk about why you're including daratumumab, because I know, when they talk about standard of care before a stem cell transplant, you may have Velcade, Revlimid, Dex, or you may have carfilzomib, Revlimid, Dex, as 2 different induction options before a stem cell transplant. But in this situation, daratumumab has been such a powerhouse, it seems like, that you're bringing it to the first setting. And for patients who don't understand clinical trials, what you were saying in the beginning of the show, when you say, these new therapies that come out, they're always tested in the relapse setting, and they take years to come to the newly diagnosed setting. So this is one of the few instances where you're using daratumumab when someone's first diagnosed in that setting, which is, I think, we should just call that out as an important thing about this study.
Correct.
So maybe you kind of want to describe why you're adding daratumumab and what effects you've seen.
Sure. So for your audience that might not be so familiar, so daratumumab is a monoclonal antibody that targets CD38, which is a protein that is expressed in the surface of all plasma cells, and that includes multiple myeloma cells. So it's an antibody that has been produced and engineered to be specific to that particular marker on the surface of CD38. And once infused, it binds almost exclusively to plasma cells and engages the individual immune system in more than one way, actually 3 or 4 different ways, and leads ultimately to to the killing of the cancer cells. So that is a fascinating concept, but one that is, it turns out, is not new into oncology. We have had monoclonal antibodies using breast cancer, lymphoma, just to mention a few, for exactly 20 years. But only recently we have had monoclonal antibodies in multiple myeloma, elotuzumab being the first one, and daratumumab being a not distant second. And the data, the clinical data, has really been quite impressive for daratumumab. Initially tested in patients who have had multiple relapses, we saw about 30% response rate with the daratumumab alone. We have seen 2 large phase 3 clinical trials in patients with relapsed myeloma comparing Revlimid, dexamethasone versus daratumumab, Revlimid, and dexamethasone in one study that's called the POLLUX study. And on another study called the CASTOR study, we saw bortezomib, dexamethasone versus daratumumab, bortezomib, and dexamethasone. And what we saw in those studies is 2 things. One, daratumumab plays well with others. So it's not a drug in the same family of the same nature than a proteasome inhibitor or an IMiD or an alkylator. So it has the side effect profile is quite different, and for the most part does not overlap in terms of side effects with either bortezomib or lenalidomide. So it plays well with others. There's little in terms of added toxicity. But what we saw was a very strong signal in terms of better efficacy. In both those trials, the addition of daratumumab reduced the risk of progression of myeloma in about 2/3 as compared to either lenalidomide alone or bortezomib alone. So that makes a very compelling case to, go up to the next level, which would be to test this myeloma agent up front. So studies are being done and have been done, testing in a proper large phase 3 setting, treatment template versus that same template plus daratumumab. And one of those studies was performed in Europe in older non-transplant eligible patients using a template that is not very popular in this country, which is bortezomib, methylprednisone versus bortezomib, methylprednisone plus daratumumab. And again, a very dramatic effect in terms of reduction in risk of progression was seen. So to us, it seems pretty evident that we adding daratumumab to other more mainstream agents would be ultimately beneficial. But the other thing that was also seen is since daratumumab helps regular agents or established agents to become more effective, we also see a higher level of elimination of minimal residual disease, even in the relapse setting, which further supports the case for using daratumumab upfront in a regimen that intends to eradicate MRD.
Right.
Other studies have used daratumumab in combination with VRD, which is a more established upfront regimen. We did intend, however, to use KRD for a couple reasons. One is that in the relapse setting, carfilzomib has been proven to be more potent than bortezomib, and prior trials using KRD in the upfront setting with transplant have shown that this combination is not only safe but also highly active and can induce elimination of MRD in a high proportion of patients. So we really felt that this combination with 4 agents would probably be the one that among the available agents in myeloma would give us the highest likelihood of clearing MRD in the highest proportion of patients.
Well, I think it's a great approach just because if you can take some of the best drugs and apply them before the myeloma has had a chance to get more complicated on you, then the better. So maybe we should talk about the importance of this first line of therapy, because I know I've talked to a lot of different experts at our meetings and things, and they always stress, what you choose for the beginning of your treatment can really impact your long-term outcomes and how your disease behaves over time. Do you want to speak to that point at all?
Absolutely, and that's an excellent point, and I cannot emphasize that enough. Oftentimes, we hear the criticism that, well, if you're going to use your best agents up front, so what are you going to do when the myeloma comes back and the patient has already been treated with your best regimens? Well, saving the best for last, as we say, is not a good strategy. Has never been proven to be beneficial in essentially any cancer, and the same is certainly not the case in multiple myeloma. if you, I think a few things to consider is the greatest remission, the longest remission that patients with myeloma will ever have tends to be the first remission. And it has been very well shown that a strategy that leads to better PFS, better progression-free survival in the upfront setting, will translate into best survival in the long run. Another aspect that oftentimes goes unrecognized is as patients progress and go through second and third and fourth line of therapy, that their fitness change and their ability to receive subsequent line of therapy does change. Every time the myeloma becomes active again, there is morbidity and mortality associated with that recurrence. That might not be the case for the patient with a more indolent myeloma, where we have the chance to slowly observe some biochemical progression for weeks or months before the disease becomes clinically evident. But it's certainly the case for some patients with more aggressive disease, where no matter how close you monitor, their disease might progress with new fractures, renal failure, and change in performance status. So there is even a mortality associated with every episode of recurrence. And the other more practical aspect is as people age and the myeloma takes additional hits on their health, they may not become eligible for a clinical trial or candidates for standard of care therapy with those novel agents up front or later on. So I think that on itself makes a very compelling case for use your drugs earlier. But if you want to take this up one notch and look at a more ambitious way, what I hope will soon become the case is that if you have the right agents and treat the right patients and have the proper tools to monitor and tailor your therapy, we really have the hope that the first therapy might become a definitive therapy. And if you are effective enough with your first line therapy, you might not have to ever worry about treating a recurrence, at least in a subset of patients. This is a very, of course, ambitious goal, and it's not a goal for one investigator or a group of investigators. Is a goal for our community of myeloma physicians, myeloma investigators, myeloma patients. But I think that's where we need to keep our focus on developing therapies up front that are effective enough that we won't even have to worry about a progression.
Yeah, that would be amazing. And sometimes that strategy is just get you out as far as possible. And if you're getting a 5, 7, 9, 10-year remission versus a 2, 3, 4-year remission, then the likelihood of having more curative therapies, even if you do relapse, is just so much higher.
Absolutely. So I think a strategy of using the best therapy up front, it pays itself off even on a static system where there's no innovation. Yeah. But in myeloma, the case is even more compelling because, as you very well know, there are novel therapies being developed on a yearly basis. And I have some, as many of my myeloma colleagues, I'm sure can give the same testimony. I have patients who are now, have 18 years, 19 years of disease. And when they were diagnosed was VAD and transplant. And essentially they have been on multiple lines of therapy. They're doing well, and they have benefit from all the innovations that came along the way. So I think if you can buy your patient a very long upfront remission, this is not only on itself a noble and a valuable outcome, but also bridge that patient to a possibility of benefiting from future therapies that can be transformational.
Yeah, I totally agree. So cure goal at the beginning and longer outcome goal as a secondary if your myeloma is not behaving in the right way that you want. I have a question for you.
Sure.
You mentioned that sometimes different patients respond in different ways, I know. And when I was going through treatment, but this was a very long time ago, sometimes my doctor said, sometimes I see patients who respond really quickly, but their myeloma relapses more quickly. And sometimes patients who take more time to get into remission respond more longer term. That was before all this MRD testing, and you could even, detect to that level. But have you seen similar things in your practice, or
absolutely.
How do you speak to that?
Yeah, anecdotally, you're absolutely right. We all have seen patients who I have patients who have never obtained more than a partial remission, who have opted not to be on maintenance and are off therapy for 6 years, doing well with no signs or symptoms of myeloma, even though the myeloma is present. And we also have seen patients who have a very quick, very quick remissions, but then have very quick progressions. And I think that speaks to the heterogeneity of multiple myeloma. As you said, disease is different on every patient. We don't fully understand why it behaves that way. Some patients have a myeloma with a more MGUS-like phenotype, and eventually you have an additional biological step and becomes multiple myeloma, and you can treat the myeloma component, but MGUS component remains stable, which may account for that long-term persistence of the malignant clone without features of multiple myeloma. But the patients who have cytogenetic high risk, the patients with 17p, 414, they're the ones who tend to have a quick responses and quick progressions. And we know now that in part, I'm not saying in totality, but in part, this is due to the fact that clearance of disease, that the initial eradication of disease is not complete. Even though some of those patients might reach a complete remission, meaning the myeloma is not promptly noted in the bone marrow exam and the immunofixation and electrophoresis are negative, they still harbor disease at a very low level. And we hope that if we can treat them up to the next level, which would be eradication of that minimal amount of disease, we might be able to break that cycle and break that paradigm and create the possibility that those deep or those quick remissions can also be definitive remissions. This has long been an aspiration, but I think we're starting to see data to support that. The French group at the last ASH meeting showed data from IFM 2009, which were patients treated with RVD, and some received transplants, some did not. But what was shown for the first time is, in at least a subset of patients, attainment of minimal residual disease negative status at the end of therapy might trump the prognostic impact of poor risk chromosomes. So in other words, if you take those patients who are high risk of recurrence based on chromosome analysis, and you can treat their disease down to undetectable by a very state-of-the-art molecular technology, they might not recur at all, and that's really an eye opener, and really sets a window of opportunity that we should pursue further.
That's wonderful. Wonderful. Now, this study, I understand, is called a single-arm study where no patients are getting randomized to different protocols. So maybe you want to explain that for patients who don't understand sometimes how studies are created and why this might be important for participating newly diagnosed patients.
Absolutely. So, randomization, there's nothing intrinsically wrong with randomization. For the scientific standpoint, the only way you can definitively conclude that treatment A is better than treatment B is when you do a large study where some patients are randomly assigned to A, other patients are randomly assigned to B, and at the end you show that one is superior to the other for a given meaningful endpoint. Those studies are very important. They take hundreds of patients and oftentimes years, many years to be completed. They are considered, definitive evidence of a benefit of a new therapy or new diagnostic test. But there are, of course, many other types of studies that have a different design and a different goal. So our study is a phase 2 non-randomized study, which means all the patients enrolled receive the same treatment plan. And the objective of the study is not to definitively prove that this approach is better than any other approach, but to generate data that is compelling enough that might support a more definitive phase 3 study that could eventually change the standard of care. So oftentimes how new treatments are developed, you first do a phase 2 and use a more short-term endpoint, and if you can obtain that endpoint on a compelling proportion of patients, that's your path to proceed and do a large phase 3 study. So on this study, all patients receive the experimental regimen. There is no comparison against another group of patients treated at the same time. We're comparing the results of this therapy with the results of the historical results that are of what is obtainable with other more traditional regimens. So it can be considered a proof of principle, essentially. We're trying to demonstrate that, one, you can use those 4 drugs in newly diagnosed patients on a safe and effective way. 2, you can obtain MRD negatively in the large proportion of patients. 3, that the majority or those patients can discontinue therapy without seeing recurrence of disease. And 4th, and perhaps just as important, is that it's feasible to operate a treatment program where you use MRD for real-time guidance of therapy. So those are the things that we hope to accomplish with this single-arm study.
Well, let's talk about MRD or minimal residual disease for a minute, because I think this is a really important thing. Now that we have more myeloma drugs and better myeloma drugs and more combinations, when you're, as an investigator, when you're trying to run these studies, people can be living, 8, 10 years. So you're really not getting your data back until many, many, many years later after you try these different combinations. So being able to test or detect disease at a much deeper, more sensitive level for these MRD tests might help you understand who's responding, who's not, and be able to come to some conclusions for us as patients earlier without waiting 8 or 10 years, because we don't really want to wait to know which might be the best option for us.
Right. So you're absolutely right. So just to explain a little bit about minimal residual disease. So traditionally, how we assess response in multiple myeloma, it's by using morphology on the bone marrow. and using serum and urine tests that look for the paraprotein that the myeloma produce. And based on those tests, a set of criteria for response has been set up and validated by International Myeloma Working Group that really has to do with the elimination of the protein and the elimination of visible abnormal plasma cells in the bone marrow. So those tests are very helpful. Those are still the bread and butter of our myeloma response assessment. But those are tests that go back, many, many decades. And for the longest time, we did not need anything better because most patients were not obtaining even a complete remission. They were obtaining no response at all, or a partial response, or a very good partial response. So it has really, for the longest time, not been that crucial to have a test that can see it better, because the majority of patients were left with a large number of plasma cells that produce an abnormal protein in the blood and in the urine. As the treatments got better, we started seeing more patients reaching what's called complete remission, which can be quite misleading. Complete remission means I cannot detect the protein in the blood or in the urine, and if I do a bone marrow, I have less than 5% of plasma cells. But we know patients can still have a lot of myeloma cells in their body and still be considered in complete remission. And the most definitive proof of that is that most patients who reach complete remission, they were still going to have a relapse later on. So as the treatments become better, the traditional methods of evaluating disease response become greatly inadequate. So just to keep that in perspective, when you say complete remission by traditional methods, that means the patient can have 1 in 100 to even 5 in 100 myeloma cells in their bone marrow, which is a lot of myeloma. But we're talking now about technologies that can detect 1 cell in 100,000 or even 1 cell in a million. And that's what we call, minimal residual disease. There has been essentially 2 methods to detect minimal residual disease. They are both being developed. There are some groups that are more aligned with one method. The other group are more aligned with other methods. They all have their pros and cons, but we foresee a future where both are going to be utilized and both are going to be helpful. One of those methods is the flow cytometry, which is utilizes essentially makes the cells from the sample, typically a bone marrow sample, those cells are treated with antibodies that detects different markers, and those cells go through a machine called flow cytometry that detects the aberrant expression of some markers that identify those cells are being malignant. This test can detect 1 cell in 10,000. The European group, particularly the Spanish group, has developed what's called Euroflow that can detect 1 cell in 100,000, and they're trying to improve this even further. Another technology is a completely DNA-based technology using what's called next-generation sequencing. That essentially consists of utilizing the patient's own bone marrow sample from the time of diagnosis, when there was an abundance of malignant cells, and identify 1 or more specific, we call clonogenic sequences, which are DNA sequences that are unique to that patient's multiple myeloma. And then once the disease is treated, you take a post-treatment sample and look for that sequence or sequences in that new sample. And that technology can detect 1 cell in 100,000 and 1 cell in a million. So what can be shown is that MRD presence in the level of MRD is clearly linked acute outcomes. So this has been shown with more than 10 years follow-up from the Spanish group using particularly flow methodology. And this has been shown more recently by the French group on the IFM 2009 study, where patients who had less than 10 to minus 6 did better than patients that had 10 to minus 5 to 10 to minus 6, which did better than patients who had 10 to minus 4 to 10 to minus 5, that did better than patients who had more than 10 to minus 4. So there's clearly a gradient effect, and there might be a level that's low enough that you can, if the patients can clear the disease, beyond that level, recurrence simply does not happen, and that would be evidently a wonderful thing. So what we have so far is this test being used as a prognosticator. If you end the initial phase of your therapy and your MRD is down to a certain level, let's say 10 to minus 6, you're better off, and your chances of recurrence are less than if it was, for example, 10 to minus 4. So it's a good surrogate of long-term endpoints. What we're trying to do is help take to the next level, make that a meaningful endpoint for clinical trials, and more important, being a stratifier of therapy. In other words, be a deciding factor of who should receive more therapy versus who should receive less therapy.
Mm-hmm. Right. And when you say 10 to the minus 6, that is 1 cell in a million, right?
That's 1 cell
in
10
to the and 10 to the minus 5 is 1 cell in 100,000.
100,000. Mm-hmm.
Yeah, and then 10 to the minus 4. So that's not very sensitive when you're just looking at 1 in 10,000, right?
Yes, 1 to minus 4 will be 1 in 10,000, and which is, you're absolutely right. It doesn't seem so sensitive, but it's still far better than just morphology and protein electrophoresis, which can miss a much higher burden of the disease.
Well, it's wonderful that these new tests are coming out, and I think the test you're using is the adaptive clonoSEQ test, right?
That's correct. The test that we use in this protocol is the clonoSEQ test that is based on next-generation sequencing.
Mm-hmm. Okay, wonderful. So just a little bit of information. Do you want to review, just details about the study, like where is it being run, and how many patients are you looking for? How do patients join?
Absolutely.
Maybe the cost, because I think what was unique about this is that carfilzomib and daratumumab are being given for free from Amgen and from Janssen, right?
Absolutely. So this study is a investigator-initiated study, which means me as investigator, we hold the primary responsibility over the study. The study receives financial support and drug from both Amgen and Janssen that provide carfilzomib and daratumumab respectively. The trial intends to accrue 82 patients in 7 different myeloma centers. Because we are the principal investigators and UAB is the coordinating site, the trial is started here. We had our first patient treated in mid-March, and we have close to 10 patients already identified and 4 patients who have started therapy. Eventually, the trial would open in 6 other sites. I'm fortunate to have the support and collaboration of my colleagues from Medical College of Wisconsin, Vanderbilt University, University of Wisconsin, Oregon Health Science University, Duke University, and Emory University. And we really expect the initial projection was to accrue this trial in 2 years, but I suspect we're going to be accruing in just 1 year based on the interest and the success we have had in those early days of the study. As you highlighted, the study, like any other clinical trials, that our components are considered standard of care and they are charged to the patient or to the insurance. For example, the cost of seeing the doctor, the cost of doing the main test for for traditional disease assessment, the cost of stem cell transplant. But there are components that are considered experimental and are covered by the study. In this case, are the daratumumab, the carfilzomib, and the MRD testing by itself. We were very fortunate to have had input from patient advocates on the design of this study, and our mutual friend Jim O'Mell was very instrumental in making sure that we had a design that was answer scientific questions and was also appealing for patients. So this trial, different from many other trials for newly diagnosed patients, does not have an age cap. We recognize that patients who are older than perhaps 75 might not be adequate transplant candidates, but as long as they fit the other eligibilities for the study, they can be treated, and patients who are not going to pursue transplant, they receive 4 additional cycles of KRdD data. So there are patients newly diagnosed. Oftentimes patients are diagnosed in renal failure or in the hospital setting with a new fracture, which makes it difficult for them to meet criteria such as performance status or even renal function. So this trial accepts patients who have had minimal therapy, up to 4 weeks of therapy with bortezomib, cyclophosphamide, and dexamethasone to work themselves out of a crisis, for example, acute pain or hypercalcemia or renal dysfunction, and they can still qualify for the study. Patients interested on this trial should feel free. At this point, UAB is the only site accruing, but we will have, of course, we have information posted in the clinicaltrials.gov where we have my contact information and our coordinator contact information. I'll be more than happy to talk to patients who might be interested. And as new sites get activated, we're going to make sure that information is up to date in clinicaltrials.gov so patients can look for a site in their area.
Okay, wonderful. And also we link with a clinical trial finder called SparkCures that we find to be a lot easier to use than clinicaltrials.gov. So I know that this trial is in there, and we'll include a link with the final show so people can find it also. They can help navigate at each of the different centers as well.
Much appreciated.
Yeah. So I want to, before, I have more questions, and the time is going too fast, but I do want to open it up for caller questions just in case somebody wants to ask a question. So if you have a question for Dr. Costa, you can call 347-637-2631 and press 1 on your keypad. And we have a caller at 310-5598. So go ahead with your question.
Hi, Dr. Costa. First, thank you so much. This has been so great. I just have a quick question. So I was wondering, why would a newly diagnosed patient want to consider joining this study over the standard of care treatments that they're...
Absolutely. And the reason for it is it's out of hope that a new therapy could be better. There's no proof that a new therapy is better. Otherwise, would be no need for the clinical trial. But I think the reason patients would join this study, just like a patient would join any study, is for the possibility of having access to a treatment that might be better and would not be assessed otherwise. And so that should be always the primary reason for a patient to join a clinical trial. Now, there are other potential advantages of being in a clinical trial, and they include there's an extra level of oversight and reassurance that the treatment goals follows a pre-specified plan that has been approved by multiple layers of oversight, including the FDA, the Investigational Review Board, and local scientific review committee. Patients on clinical trials end up receiving an extra attention in addition to the regular clinical staff. There's a research staff that makes sure that every toxicity is properly evaluated, graded, and the necessary corrections are made. And the last, and sometimes we don't present that as being a motive for patients, but I'm sure many patients feel good about this, is at the end you're also contributing to generate knowledge and pave the way for future patients.
Gotcha. Well, it sounds like a great study. So thank you so much for everything you shared.
Absolutely. Thank you so much.
Okay, thank you. And one last question for you before we end. If patients have, because this isn't in the newly diagnosed setting, and so most of the time patients will have gone to their doctor and they might have gone to a local community center or something, and someone may have started them on any kind of treatment. Does it make them eligible or ineligible, for participation in this study if they've already received some kind of prior therapy?
Yeah, that's a good question. And most studies for newly diagnosed patients, if you have received one dose of anything, you are excluded. This study, it's not like that. And we wrote the eligibility in that way, essentially to capture those patients that you described.
Right.
So if patients have received up to 4 doses of bortezomib, or if they have received up to 4 doses of cyclophosphamide, or if they have received up to 4 doses of dexamethasone within 4 weeks period of time, they are still eligible for the study, as long as information that details the disease stage and the level of the paraprotein at the time of diagnosis is available. So patients who have received minimal therapy, they still can be enrolled.
Right, because when you start therapy, of course, hopefully your myeloma is going to go down, and then, you're not using a good baseline of disease burden, right?
Absolutely.
So you can't measure it or detect and try to figure out what's working better. Well, amazing. Well, we are so thankful that you have shared this study with us, and it's been just so valuable to learn more about it. And again, I was diagnosed in 2010, and there weren't these types of options, but this is a study that I would have really seriously considered and tried to learn more about, because I just think it takes some of the best available treatments and then gives you just one of the best options for long-term remissions. So thank you for putting this study together and all your work. I can't imagine how difficult it was to try to put 4 different drugs together in a study.
Thank you so much for the opportunity. And you're absolutely right. It was quite a bit of, still has been quite a bit of effort to align 2 different companies. The FDA, who has some very specific criteria to allow us to use MRD for decision making, and the endorsement of the patient community is extremely meaningful and really gives purpose for the work we do. And we're very excited to have the opportunity, the privilege to run a study like this, and hopefully that will translate into better outcomes for our patients. And thank you very much for the opportunity.
Oh, thank you, and I believe it will. I really do. So thank you so much for joining us, and thank you for our listeners for tuning in to Myeloma Crowd Radio, and we hope you tune in next time to learn more about the latest in myeloma research and what it means for you.
Hello, it is Ryan, and I was on a flight the other day playing one of my favorite social spin slot games on ChumbaCasino.com. I looked over at the person sitting next to me, and you know what they were doing? They were also playing Chumba Casino. Coincidence? I think not. Everybody's loving having fun with it. Chumba Casino is home to hundreds of casino-style games that you can play for free anytime, anywhere, even at 30,000 feet. So sign up now at ChumbaCasino.com to claim your free welcome bonus. That's ChumbaCasino.com and live the Chumba life.
No purchase necessary. VGW Group. Void where prohibited by law. See terms and conditions. 18+.